I want to introduce the last speaker. It's Professor Micheal Boettcher from Mannheim. He's Chief of Pediatric Surgery at the University of Mannheim. For many years, he has been working in Hamburg as a chief senior physician. And as you may know, Mannheim is repairing and treating maybe almost over every second child with CDH in Germany. And he will share now his experience in the interdisciplinary approach to that disease. And maybe we can transfer some of that on the treatment of EA. Michael, please.
Thank you. So thank you very much. Unfortunately, Professor Scheible cannot be here today because he's got sick, but I will try my best in order to compensate for that. Because a lot of that, what was achieved in Mannheim, is due to him, or is owing to him. But in general, in CDH, we have come a long way. So if you look at mortality rate, 50 years ago, it has come down from almost 70% to 25% internationally. In Mannheim, it's even a little bit lower. And ECMO, which is a great factor in the management of CDH, even in that, mortality has decreased over time. And also in the long run, if you look at health-related quality of care and mental health and IQ, we have differences at the beginning, but they subside over time. And by school age, especially the non-ECMO patients, they're almost at the same level as healthy controls. And so in Mannheim, we have it's not every second child, it's more 1/3 or so. So we have very high numbers, and we are highly specialized for that. So much so that FETO, which has been well established for CDH, especially for the severe cases, it almost got significant also for the moderate cases, and has been published in the New England Journal 2 years ago, led by Jan de Prest. But when we are comparing 3 centers that were utilizing FETO primarily, and we're comparing that to the management in Mannheim, it appears that ECMO is superior. And this could mean that ECMO is actually superior. It could also mean that their very high numbers and the specialization in Mannheim led to this result. So we don't know. But as a surgeon, I believe in numbers. So if you look at the oncology, so pediatric oncology and also congenital malformations, we have around the same numbers. But we achieved centralization in oncology, but not as much in congenital malformation. So in Germany, we have around 180 CDH patients, 160 make it to the OR. And for instance, if you want to do a complex surgery like thoracoscopic CDH repair, you have quite a high learning curve, and you need 33 cases in order to overcome the learning curve. And in most centers, this probably means that they can teach 1 or 2 surgeons every 6 years. So if you look at the caseload for simple case, there's no effect, but we were able to establish that higher caseload for central venous catheters already improves the outcome. This is well established on the individual, but also center level for heart surgery. And that's why they centralized it and they introduced minimal numbers. And we haven't done that for CDH, not directly, but there's some specialization. There's 2 centers that have higher numbers. Leipzig has quite high, increasing at time, but there's a very high proportion of CDH patients that are treated in centers with 1 or 2 cases. To establish that there's a volume outcome correlation, we're asking the German Ministry of Statistics that collect all the insurance data, and we looked at the mortality for ECMO for CDH, and then we divided them by 10, so low volume center has less than 10 cases, 10 to 20 was an intermediate, and above 20 you had a high volume center. And as you can see, the mortality is half if you go to a high volume center. And this is well established in other studies. If you look at studies from Canada and the US, there's almost a linear decrease in mortality if you go to a center with a higher caseload. So, yeah, it's a thoracoscopic repair of a CDH patient with a B defect. This is a medium defect. And we do all these repairs in A and B and C defects if they don't have pulmonary hypertension. And because it's so specialized, we have so many cases, around 30 to 40 cases per year. This surgery only takes us a little bit over 1 hour, and we almost always use a patch, so it's cut. And due to the high numbers, we were able to bring down the operative time for open and also for minimal invasive surgery for CDH repair, but also what is more important, the recurrence rate. Lately, we have been dropping to 7%, for instance, for thoracoscopic. And if you look at the international literature, you have almost double the numbers. And also for the recurrent cases, we started to operate them minimally invasively in order to avoid the adhesiolysis. If you go for an abdominal approach, you have the problem that you create a lot. It takes quite a long, and it creates quite a lot of problems. And as you can see, we were able to reduce the stay on the ICU unit. Most patients don't have to go there, and also reduce their hospital time. And another possibility, if you have these high numbers, is you can try out new things. So, for instance, many patients with CDH, they develop over time during the growth because the patch is not expanding. They develop GERD, and the hiatus is pulled open. And so we started repairing that thoracoscopically in order to avoid adhesiolysis again. And as you can see, it's quite fast. We have no complications. They don't have to go to the ICU unit. They go home very fast, and until now it was always successful. But yeah, we only have a very short follow-up time. Probably for fundo it also works at the beginning, and after a while the effect subsides. And so I think in order to try out new things and to really optimize the management, you need higher numbers, but you also need a structured, lifelong, interdisciplinary, multimodal follow-up, and that's what we created in Mannheim. So when I came to Mannheim, we stopped at the age of 18, and now we expanded that for a lifelong follow-up in order to evaluate what kind of techniques are working, and also to pick out the patients that need further support. And we also applied the multi-omics approach. And I think this kind of, if you have a very active follow-up program and the patients really stick to the follow-up, we get them involved, we get them interested in the follow-up program right at the very contact during the first counseling. And I think this can really help to improve the overall management of the patient, because not always is it the lung hypoplasia that leads to a bad outcome. Sometimes it seems to be different factors, and we try to evaluate which these are. So now we come to the slides from Professor Scheible, and he wanted to point out again that CDH is a very challenging disease, and you have this trifactor of CDH, meaning that which includes pulmonary hypertension. They have small lungs, they have a very high pulmonary hypertension, and have a heart dysfunction. You need an entire team, you need a standardized approach in order to avoid a pulmonary hypertension crisis. And ECMO can be a great deal in order to overcome all these problems, especially to overcome a hypertension crisis. So ECMO has been also the main marketing factor to have this indirect special centralization. So at the beginning, 25 years ago, Professor Scheible established the ECMO program, and they went to the other hospitals and they cannulated the children and brought them on ECMO back to Mannheim. And over time, as the prenatal diagnosis improved, it used to be 20% 20 years ago, obviously, and today we are around 80 to 90%. And now this centralization is done prenatally. So when there's a child with a higher risk of ECMO or severe CDH and pulmonary hypertension, then they are transferred to a reference center, or at least an ECMO center. And according to that, the numbers were increasing. There's some hit during COVID due to the shortage of the nursing staff, but at the moment it's still recovering again. So a lot seems solved, but there's still a problem because we always try to do a risk stratification, and we judge the children depending on the ultrasound or MRI. We use the expected to lung to head ratio, so it means we measure the lung compared to the head, and then we compare a healthy to an affected child. So it seems that even if the child is considered to have a mild lung hypoplasia, which correlates well with the survival of the child, there's still 20 to 30% that end up on ECMO, which probably means we need centralization even for the considered milder cases. So in order to manage CDH patients well, you need quite a lot. You need an accurate prenatal diagnosis as long as we don't centralize. You need standardized prenatal and postnatal care. You probably need all the options, which includes ECMO, and you probably, I think, which is really essential, a structured follow-up. One of the most important factors in order to bring the patients to your center and to create a indirect centralization is a multidisciplinary approach, which starts prenatally. So when the gynecologist suspects CDH, he involves us, so the neonatologist and the pediatric surgeon have first contact to the patient. We give them first information, and if it's confirmed later on, we will continue the counseling. We will get involved the entire CDH team, which includes the fetal surgeon, the nurses at the ICU ward, and so on. And then we plan the birth with the obstetrician. And I think this step to get the entire team involved is very essential. And we do the same thing, so the same team of persons will also be present at the follow-up program. So we accomplished quite a lot, but there are still problems. For instance, what we are seeing is that the children are doing quite well at the beginning, but the lung function seems to deteriorating in some patients, and until now we don't know why this happens. It's not always the lung hypoplasia. There are some patients like this famous football player, he's also part of the Swiss national team. Some patients are doing quite well, and I think it will be one of the tasks that we have to do to find out which patients and why they're doing better than others, and that's why we need this structured follow-up program. So what are the takeaways for EA? I think as long as we don't have a federal centralization, we should try to increase the prenatal diagnosis, which is probably quite challenging. I don't think fetal surgery will help us a lot. Probably the interdisciplinary prenatal counseling will help, but we don't have a ECMO. We don't have this killer marketing tool. Can't think of anything. It might be minimal invasive surgery, but I'm not sure if any parents will have enough time to get informed enough and to make this choice if they weren't aware before birth that the child may have EA. And I think in order to make meaningful clinical but also basic research, we need this multidisciplinary structured lifelong follow-up, because Professor Scheible and I and Richard Martel, he's sitting in the back, and Julia Elliott, so we are kind of the case managers in the follow-up program. We send them to all the other tests and the other experts within the hospital and also outside of the hospital, for instance, for the adult patients in the thorax clinic in Heidelberg. And then we collect all the data, and I think this will help us to pick out the patients that need extra support and also to hopefully find out why some patients are doing much better than others. Thank you very much.